So good evening, everyone. Welcome to the American Society of Geriatric Otolaryngology webinar today. We have the pleasure of having Dr. Sara Abu-Ghanem present to us today. She's an otolaryngologist with expertise in laryngology. She received her residency training in otolaryngology and head and neck surgery at Tel Aviv Sourasky Medical Center and completed two-year clinical fellowship in laryngology and bronchoesophagology at Stanford University School of Medicine in California and New York University School of Medicine in New York. Dr. Abu-Ghanem is a faculty member in the Department of Surgery at Maimonides Medical Center and is also an assistant professor of otolaryngology at SUNY Downstate. She serves as co-director of the Maimonides Swallowing Center. On a national level, Dr. Abu-Ghanem contributes to several professional societies, including the American Laryngologic Association, serving as postgraduate committee member, the American Society of Geriatric Otolaryngology as an executive council member, and the American Bronchoesophagology, Esophagologic Association on the Pharyngoesophageal Committee. She is also the current chair of the Airway and Swallowing Committee for the American Academy of Otolaryngology, Head and Neck Surgery. It's my pleasure to introduce to some and present to others, Dr. Abu-Ghanem.
Thank you so much. Okay, I'm gonna make sure. So you guys see my screen, correct?
We see your screen. It's not in presenter view yet.
Okay, so I'm gonna put it in a presenter mode.
Yep, it's good. We see it now.
Mm-hmm. Okay, perfect. So in the next, I guess, 30 minutes or so, I'm gonna present my new interest in the past few years, sarcopenic dysphagia, and share with you our experience and some thoughts about that specific topic. As mentioned, I'm part of Maimonides and SUNY Downstate, and you guys are more than free to reach out if you have any questions or comments after this lecture, for sure. I first want to start by thanking the Frank Lucenti Resident Research Grant, part of the SUNY Downstate Otolaryngology Department. This grant basically allows us right now to run our own prospective study on this specific topic and acknowledge two excellent residents, Dr. Graf, our chief resident that is graduating this year and going to, unfortunately, to facial plastics, although I really wanted him to go to laryngology, and Dr. Govind, and I want to thank them both. As you can see here in this graph, significant and fast advances in medicine, health biology, social and economical factors have led to significant increase in life expectancy. And demographers predict that by the year 2050, the proportion of the global population aged 65 and older is expected to rise to 16%. If we're looking just at the US population, we expect that these population of 65 year and older are going to be 25% of the population. As you probably experienced yourself in your own practice, as time goes by, we just notice that our patients are getting older and older. And we can see the same thing here in this graph. As expected in this period, in this graph from 2010 to 2050, just see the estimated percentage change that is expected. I was amazed by the age group of 100 and plus that we're going to see more and more in the next few years. Obviously, this trend puts geriatrics, and this society is part of it, geriatric medicine and gerontology, the study of aging, to be extremely important as part of healthcare. One of the main drivers for that is the increased healthcare demand and utilization among elderly, mostly given the high prevalence of multiple chronic conditions. Based on this, I'd really encourage people that want to read more about it, about the healthcare and aging. This paper was published just this year in Nature Aging, and basically shows that and cite that according to the CDC, 90% of older adults, I would say, have at least one multiple chronic condition. And this is obviously associated with higher morbidity, mortality, and functional decline. Another aspect in geriatrics is this concept that is called geriatric syndrome. The term of geriatric syndrome, if you guys are not familiar with it, was first described almost over 100 years ago. In general, geriatric syndrome represents a group of common conditions, not necessarily in aged population, but more common in aging population. And these specific geriatric syndromes have a lot of impact on these patients and their quality of life. In general, when we look back at medical school and we think about the concept of syndrome, what is syndrome? Syndrome is basically a pattern of symptoms and signs with a single underlying cause that maybe at the beginning when we see these patients, we're not really sure what that is. However, when we look at the geriatric syndromes, there are multiple risk factors, multiple organ systems, and diagnostic strategies are not necessarily going to help us with even finding what the cause is. Another thing that we're going to notice in geriatric syndromes, it's sometimes we're going to be treating geriatric syndrome without even knowing what the cause is. What are the examples of geriatric syndromes? These are just part of them, but the main ones are pressure ulcers, falls, incontinence, delirium, depression, dizziness. Again, all of these conditions are very common, but more in aging population, and not necessarily we're going to have the cause for it. In 2016, the European Society for Swallowing Disorders and the European Geriatric Medicine Society, they published a consensus statement that basically recognized oropharyngeal dysphagia as the new geriatric syndrome. When we think about the aging on swallowing function, we need to really understand what is normal swallowing for older patients. And based on that, we need to have better expectation in terms of what we're going to expect in terms of symptoms or instrumental evaluation. Why is that important? Because this is important in order for us to avoid overdiagnosis and overtreatment of patients. As you can expect, the aging can affect the three different swallows stages, the oral, pharyngeal, and esophageal. And in the next two slides, you can see here basically in this slide, you can see the oral changes that are expected with aging. Some of them are obviously very common, and you can think about it by yourself, like number of teeth, the muscle strength, the amount of saliva that is produced. When we look at the pharyngeal, and the esophageal phases, again, these phases can also be affected normally by aging. The two major changes we need to keep in mind that is related to dysphagia, or I would say to swallowing mechanism, are muscular weakness and sensory dysfunction. I want to move forward with the next definition, which is basically presbyphagia. So if we're saying that it's also normal as part of aging for our swallowing to change, therefore primary dysphagia is basically refers to age-related changes in the swallowing mechanism that are part of the healthy aging. Some people look at primary presbyphagia as putting the older patient or person prone to have dysphagia under acute settings. Imagine these patients, normally they're able to compensate those deficiencies or this dysfunction. However, when they're going to have pneumonia or they're going to be having any other acute illness, this can manifest later on as overt dysphagia. Secondary presbyphagia is just that term, refers to swallowing changes due to diseases in the elderly, basically triggers that disrupt the weak equilibrium. When we look at the common causes of oropharyngeal dysphagia in the elderly, I really encourage anyone who is interested in this textbook to know more about oropharyngeal dysphagia. In this textbook, they basically, in this specific chapter, they divide those different causes to neurological, structural, metabolic, infectious, and iatrogenic, as you can see here below. Obviously, one of the most common causes, as you can see, you probably see in your own practice, is the neurological one, like stroke, etc. We wrote this paper this review when I was a fellow, and I remember when I was studying or writing this review, I came across muscular changes as cause for oropharyngeal dysphagia. And I thought to myself, this is a kind of interesting topic. Why would change in muscles will cause dysphagia? And that led me basically to look at the literature and see what is it out there about sarcopenia or change in muscles that can affect dysphagia. To my surprise, as you can see here, just by quick search on PubMed or Medline, very limited number of publications are out there about this specific topic. Otherwise, you can also see the increased interest in dysphagia in elderly, again, mostly because of our aging population. So let's go back to medical school and try and remember the definitions of sarcopenia. The definition of sarcopenia is basically the condition that causes progressive loss of muscle mass, strength, and function. Try and remember this mass, strength, and function, because later on, you're going to see why this is important. Again, when we look at the etiology for sarcopenia, part of it is age-related, and that's therefore will be just primary sarcopenia. But some of it can be just secondary sarcopenia. Think about these patients that are G-tube dependent. Think about these patients that will be the nutrition-related one. Think about those very sick patients that also can develop sarcopenia, or patients with lower activity levels that also can obviously affect sarcopenia. So to summarize, we have primary sarcopenia generally related to aging, and secondary sarcopenia related to specific cause. When we look at sarcopenic dysphagia is basically the difficulty swallowing associated with both generalized skeletal mass loss and swallowing-related muscle loss. The sarcopenic dysphagia is considered to be pretty new entity. As you saw, most of the publications are in the last few years and very limited one. And interestingly, when we think back about the definition of geriatric syndromes, both the sarcopenia and oropharyngeal dysphagia were described separately as geriatric syndromes by themselves. Again, when I started looking into see what is sarcopenic dysphagia and what are the criteria to define this specific entity, this was first described in 2013. It was proposed at the 19th annual meeting, the Japanese Society of Dysphagia. And the Japanese group basically defined specific criteria. In order for us to say sarcopenic dysphagia, obviously there needs to be presence of dysphagia. We need to see loss of skeletal mass and strength, generalized mass, and also changes as expected in swallowing muscles as well. And the last criteria is basically that there's no other causes for the dysphagia. In 2017, diagnostic algorithm was basically developed based on those criteria, and basically looked at the different criteria in terms of muscle and strength in order to define those, in order to define sarcopenic dysphagia. We're going to get into that in more detail later on. Basically, all this after, looking into the literature, seeing the very limited publications out there, that led us basically to look into understanding more the current literature and critically evaluate the tools used to diagnose sarcopenic dysphagia in the elderly. And I want to share with you our results. Part of our critical review was first when I sat down with my residents and we tried to identify what are the challenges when we're studying dysphagia in the elderly or trying to study sarcopenic dysphagia. What are the challenges that we might face when we try to study these patients? The first challenge we came or thought about is basically the cutoff of older population. When I first got into this interest in geriatric dysphagia, looking at the literature, it was kind of hard to understand what is really the cutoff, because it seems like across different publications, this cutoff kept on shifting. Obviously, as we all know from medical school and from our work, the medical treatment in the elderly is usually defined as 65-year-old. However, different conditions might shift this cutoff to be higher or lower. and if one of you is interested in this specific topic, we saw some publication defined dysphagia in the elderly as 50 years and older, and some of them actually older than that. Another challenge we identified is the subgroups within older population. We can't assume that 65 and older are the same, 65 and 70, between 65 and 75 is the same as over 100 years and older. So even within this geriatric population or elderly population, there is another important aspect is the subgroups of these population and cannot be treated all the same. The third challenge we identified when we're thinking about dysphagia in the elderly is basically the different settings. Obviously, patients in the community are not the same as patients in the hospital or hospitalized inpatients, and not the same as nursing home. The numbers that you see here is just like general number of dysphagia that is expected in these subgroups. So obviously, in nursing homes, the dysphagia rates is going to be much higher. When we are planning to do some kind of study or we're reading curriculum, trying to be more objective when we're reading kind of study or publication, we're trying to identify what is the population that was studied. And was it a mixed population? Because obviously mixed population is not all the same. And this is from the same textbook that I mentioned before. You can see here the different prevalence of oropharyngeal dysphagia in the different setting. Again, as we expect, the community are going to be lower than the nursing home. The fourth challenge that we identified when we're thinking about oropharyngeal dysphagia in the elderly, or in general, studies that look into dysphagia, is the definition of dysphagia that was used. As we already know, dysphagia is subjective is a subjective sensation of difficulty swallowing liquids, solids, or both. But it's extremely important to differentiate between dysphagia from swallowing dysfunction. I really like this this paper that Dr. Rameau and the team published just 2 years ago about how we use dysphagia and how very often dysphagia is used inaccurately. They looked at very randomly, they chose a number of papers that were published in a certain time of period, and they looked to see how many times the word or the term dysphagia was used inaccurately. Obviously, in order for us to assess dysphagia and swallowing dysfunctions are two different separate things. And they identified that close to 40% of those publications that were published use those terms together. And we're going to explain later on why it's extremely important to differentiate between the both. To summarize, their conclusion is dysphagia is a symptom, not a sign, and must be differentiated from objective evidence of swallowing impairment on instrumental evaluation. So how do we really differentiate between the dysphagia, the symptom, and swallowing dysfunction? In general, the dysphagia symptom, we assess by taking history and talking to the patient. There are subjective measures that we can use, like questionnaires. One very common questionnaire is the E10 that most of us, if we are interested in dysphagia, will be using in our own practice. Another very common subjective assessment is, for instance, use of scales. This one specifically is the food intake level scale, is basically to grade the severity of the dysphagia of the patient based on what they're able to eat. If they're eating full diet, then that means their dysphagia is obviously less. If they only able to have thickeners and softer diet, then that means they have a dysphagia. However, this needs to be differentiated from swallowing dysfunction. Swallowing dysfunction is actually using objective measures. Most common one are the Fees and modified Byron for oropharyngeal dysphagia. You found that the patient actually have what we call swallowing dysfunction, actual impairment, and not just the symptom. Why is it important? It's important because when we look at those symptoms, we need to identify using specific tools if the patient has swallowing dysfunction, and in order for us to basically prevent or reduce the complication of those swallowing dysfunction. How do we test the swallowing dysfunction? As I mentioned 2 seconds ago, The two main studies out there are basically the modified barium swallow study, also known as the video fluoroscopy, and the FEES, the fiber optic endoscopic evaluation of swallowing. If you guys are not seeing a lot of these dysphagia patients, that just to remind us from our residency, basically, as you can see here on the right is FEES, where usually this study is done by speech language pathologists. They give the patient food or different textures with dye on the left if it's modified barium, and food dye on the right if it's a FEES. And they're looking to see the safety and efficiency of swallow based on if the patient penetrated or aspirated. That's the safety part of it. And if there is any residue seen, that's a part of the efficiency of swallow. The fifth challenge that we identified when we're looking specifically at sarcopenic dysphagia is, how do you define sarcopenia? So we looked at the literature and we tried to find, is there any consensus statement? Is there anything out there that can define sarcopenia? And we found this, the main basically consensus statement out there is the European Consensus on Sarcopenia. The first edition was published in 2010. And if you recall from before, when we talked about sarcopenia, we said it's the loss of muscle mass, strength, and function. And the first consensus statement, the focus was loss of mass. However, the revised consensus statement that was published in 2018 put still mass is important, but then this time in this consensus statement, the strength is more important than mass in terms of definition of defining or identifying sarcopenia in a patient. Last sixth challenge that we identified when we look at sarcopenic dysphagia or the diagnosis of sarcopenic dysphagia are the tools used. As you can see here, this is just a quick summary of what can you use if you want to look, when you want to test muscle mass. You can use CAT scan, you can do MRI, you can do other tests that you can see there. Another is for muscle strength. Again, different tools are out there. As you expect, if there are so many different tools, that can also lead to different results, different cutoffs. And all these are not validated so much, and we can talk about it in a second too. Okay, so now we identified all the problems that we can have with studying sarcopenic dysphagia. And these are the 6 challenges that I mentioned before. The next step for us was to look at the literature. What is out there, and are the publication out there really answer those specific challenges? Overall, we identified 14 studies that we included in this in our critical review. We found that all the included studies that we included, all of them published after the publication of the sarcopenic dysphagia criteria. Interestingly, most of the publication, 13 out of 14, were from Japan. Another interesting observation, taking back to the different settings that we talked before, is 80% of these publications were in the inpatient population. Just that by itself, you can think about, wait a minute, the patient is an inpatient. We're looking at sarcopenic dysphagia in this specific population. There are so many other causes that this patient can have sarcopenia or dysphagia or et cetera. Interestingly, although all these patients, all those publications included were basically talking about sarcopenic dysphagia, less than 60% of them actually cited or explained their algorithm or the criteria or the methods that they use to diagnose sarcopenic dysphagia. If I want to look into those studies specifically, let's go back to the algorithm. So if we said before that in order for us to identify sarcopenia, we need to have lower strength, lower function, and lower mass. That's general muscle, and also lower swallowing muscle strength. When we look at the literature itself, as I summarized it here, we can see really inconsistent tools that were used in the sarcopenic dysphagia literature to diagnose sarcopenia. Also, we found that the new sarcopenia measures or new sarcopenia consensus statement is not really reflected in these studies. In most of these studies, the skeletal mass is the main important thing to diagnose sarcopenia. And we know now after 2018, it's actually the strength that is more important. The next part we'll look at is the dysphagia itself. How were these patients were diagnosed with dysphagia in those studies of sarcopenic dysphagia? When we look at the initial consensus statement on the criteria, the initial criteria for sarcopenic dysphagia, dysphagia there was diagnosed based on subjective measures like the E10, but it also required to have instrumental evaluation like FEES or modified barium. However, when we look at the diagnostic algorithm that was published later on, none of that is included in order to diagnose patient with dysphagia. Obviously, that's going to be reflected also in the literature that is out there. And only 2 of 14 of the studies that we identified as sarcopenic dysphagia even looked at swallowing dysfunction. All this shows us that the literature out there on sarcopenic dysphagia, again, just like the sarcopenia measures, the dysphagia measures are also lacking, and there's missing validation against objective measures of swallowing dysfunction. To summarize, it's extremely crucial to be familiar with the common causes of dysphagia in the elderly and the cross-interaction between presbyphagia, sarcopenia, and overt dysphagia. And we feel like there need to be more research to validate the sarcopenic dysphagia diagnostic tool, establish cutoffs in a variety of populations and settings, and investigate their role and validate them against swallowing dysfunction tools. We also think that there needs to be maybe easier diagnostic tool and algorithm that can be used in different settings. I'm not going to present our study right now, but I can share with you just briefly what we're doing right now. We are currently recruiting patients. We're looking prospectively in the outpatient setting only. At patients above 65, we actually now lower down to see if it's actually the cutoff can be lowered. And we're looking at patients with no other cause for dysphagia that have the symptom of dysphagia based on the E10 questionnaire. All these patients are going to go, will have modified barium as expected if they have suspected oropharyngeal dysphagia. And if indeed they have no other causes for dysphagia, we're going to be looking at the presence of sarcopenia. In order to look at this presence of sarcopenia, we're going to focus on the new consensus statement on sarcopenia using very basic tools like hand grip test, calf circumference as a general body mass index, and a YOPI tool to look at swallowing muscle strength. How is this going to be important in the future and how this can be used in the future? Think about it. I like to envision it as simple tools for the speech pathologist or internal medicine or geriatric doctor that is sitting with these patients in whatever setting that will be, and using very specific, very simple tools like hand grip, cough measure, and questionnaire to understand if indeed sarcopenia is affecting their swallowing and if these patients need to be further screened. I want to encourage you all. I have my own copy of this great textbook that I encourage you if you are interested in managing swallowing dysfunction in the older population. And if you want to read just a tiny bit more general stuff or more like intro, I would say, we wrote a small introduction about this topic as part of the June Dysphagia Awareness Month in the Academy Bulletin. And that is it.
Awesome. Thank you so much. Very informative.
I know it's an interesting topic to be interested in, but I kind of enjoy it very much. So I can talk about this for hours.
Well, definitely. And I think we've all had the experience of having, patients presenting to our clinics with those complaints and concerns. So it's good to have that framework of kind of how to proceed and how to refer
Yes.
as well as a otologist. Any questions from the group or comments from the audience? No, was that thorough?
Yeah. Perfect. Well, I encourage you all, I guess, to assess.
Here we go.
Keep in mind.
How are sorry, I see one in the chat. How are you using modified barium swallow results, outcomes?
It's a great question. We're actually going to look specifically at the pharyngeal part of it. There is a lot of studies, that showing as the pharyngeal part or the pharyngeal squeeze as an indicator for pharyngeal strength or muscle strength, swallowing strength. So we're going to focus on that. And our goal is basically to see if there is any correlation between sarcopenia measures to the pharyngeal abnormalities seen on modified barium, specifically at the pharyngeal phase.
Is there...
Oh, we have a visitor from Yemen. Oh, shukran. Thank you.
Is there any way to retrospectively diagnose patients with sarcopenia if none of those tests were listed or completed? Is there a way to research for research purposes?
Again, sorry about the question.
It says, is there any way to retrospectively diagnose patients with sarcopenia if none of those tests were listed were completed? Is there a way for research purposes?
You mean my study or the what was?
No, so say somebody has a patient and they want to kind of evaluate to see if they had sarcopenia. Retrospectively looking through their chart, if they didn't perform any of the tests that you recommended or that you listed, is there a way of
I think
making that diagnosis?
The best way to really assess sarcopenia, I would say in our clinical, it's kind of hard to do it retrospectively if you don't have the measures. It can only be done, even our own study, we're looking to see in patient the sarcopenia and dysphagia measures within less than 90 days. Because especially in elderly, every small illness can really throw them, really change a lot of things, right? Today, the patient is fine. Tomorrow, he gets pneumonia. The next time you're going to see him in the clinic is like, what happened to you? So it's not as adults, right? They're more fragile. So it is important to look at, in terms of setting both the sarcopenia and dysphagia, is to look at it together during the same time. It's kind of hard to look at it back, especially since there can be a lot of changes that can happen acutely in these patients.
Thank you.
Of course. Great. I'm so excited. People are find this interesting. Wonderful. Thank you.
Wonderful
Okay, so
presentation.
I guess if anyone has any questions or want to reach out or collaborate, I'm more than happy. This is something I'm really passionate about. I'm more than happy to hear more ideas and ways to collaborate.
Thank you so much again.
Thank
Great
you.
presentation. Thank you.
Of course.
Thank you, everyone.
Have a good
a
one.
great evening.
Thank you. Bye-bye.